This session is entitled From Ink to Action, Are NHS Strategies Transforming Healthcare or Collecting Dust? And I will pass over to the chairperson for this session, Phil Evans.
Thank you. Okay, thank you everyone and good morning. Welcome to this session. So just to repeat the title, the session is entitled From Ink to Action, Are NHS Strategies Transforming Healthcare or Collecting Dust? Firstly, apologies for the nasal overtones. That's me, it's not the sound system. But we'll press on. So my name is Phil. I'm a commercial and business development consultant for health tech and digital health companies. And that's all I'll say about me. You're not here to listen to me. You are here to listen to our distinguished panel. And I'll ask them to introduce themselves in a moment. And we're going to be taking a deep dive into the world of NHS strategy, or as deep a dive as we can within 35 to 40 minutes. So I guess it goes without saying, doesn't it, that the whole strategic landscape of the NHS is a crucially important one. We've got rising demand, we've got tight budgets, we've got workforce pressures. Where does strategy sit within all of that? These strategic documents that we see in every single layer of the system, local, national, regional, what are they there for? And what are they actually doing? Are they facilitating change? Or are they just sort of nice to have wish lists? Or something in between? So our panel is here to help us demystify all of this today. No pressure. And at the end of this, I'd like to come to you, our audience, for any particular questions. No doubt, if you're working within strategic roles yourselves, you'll have insights, you'll have challenges. So please, as we're going through the questions today, please have a think about what you can contribute, any challenges or questions that you'd like to raise. So with that introduction, I'll start by asking each member of our panel just to introduce themselves. Tell us a little bit about their background and set out their strategic stall. Do you see what I did there? For a few minutes. So, Chris, let's go to you first, please. Can we have this mic working?
Turn it off and on again. My name is Chris Fleming. Hello, everyone. Thanks for the intro, Phil, and thanks for the invite to this panel with a suitably provocative title. So I'm really looking forward to the discussion today. I'm a partner at an organisation called Public Digital. We're a digital transformation consultancy, and I lead our healthcare practice there. We sort of consult on projects at kind of local, system, and national level in the NHS. But prior to joining Public Digital, I worked in the NHS on digital transformation projects, including, I don't know if anyone was in the panel just preceding, but Joe Harrison described the NHS app as the most successful NHS IT project of all time. So I was program director for the NHS app. I'm quite happy to take that one. He's probably referring to the time after I left, but I have to clarify that with him. But so I have a kind of lot of experience of at scale, product, system, platform kind of transformation. And one of the projects I've been working on for the last few years in the context of Public Digital is a joint project with NHS providers called the Digital Boards Programme. And the Digital Boards Programme provides digital leadership kind of coaching and workshops for the boards of trusts and integrated care boards. And as part of that programme, a couple of years ago, we published a guide to strategy. And so just to set out my stall, I'm going to pick out my favourite 3 points from that guide before we get into the discussion. So the first thing is understanding that strategy is really choice. Strategy is about making difficult decisions, explaining trade-offs, and delivering on priorities. Strategy is not looking at all the random stuff you're doing and identifying some themes that pull it together. And a lot of the strategy in the NHS long-term plan, sort of looking at you there, kind of fall into that latter camp. So that's the first thing, strategy is choice. The second is that strategy should be based on evidence rather than hopeful guesswork from the highest paid person in the room. And So if you have particular problems, your strategy should be oriented about solving those first. And thirdly, it's that your strategy should not be one and done. The key to good strategy is really checking back in regularly. Are you doing what you said you would do? The world is inherently unpredictable. People are unpredictable. So continuing back to sort of check in and make sure you're on track is really important. And actually, as we are talking, Pat McFadden, who's the Chancellor of the Duke of Lancaster, is giving a speech over in UCL in East London, where he's setting out the government's policy for civil service reform. And he is making a similar point today, which is that the world is too complicated to design up front. So making sure we find ways of testing, evidentially based testing and learning, pivoting, and adjusting our design is a really important part of that. So I think that's key to strategy as well. It's really exciting to hear that. That's me. Look forward to the discussion. Thank you.
Great. Thank you, Chris. Anna, over to you.
Good morning. Is that working? It is. Good. Lots of nods. Good morning, everybody. My name is Anna Bokobza. I am Director of Strategy at Essex Partnership University NHS Foundation Trust. You need quite a big lanyard to write that all down. We call ourselves EPUT, and we are a large community and mental health trust that serves over 3.2 million residents across Greater Essex, portions of Suffolk, Bedfordshire and Luton. I have been in this role for 2 years, so I am the author of some of the dust collecting documents that we're going to be talking about. Previous life, 12 years in a large West London acute multi-site teaching hospital trust. You can work out which it is or look it up on my LinkedIn profile. But there I had a variety of different roles, going from business development, operational planning, further and further towards the front line and further towards operational leadership. And in the last sort of 6 years there, so through the pandemic, was really focusing on the interface between acute trusts, acute hospital trusts, and how they interface at place level with primary care, with social care, with voluntary sector partners, and most importantly, with their communities. Grew up as a management consultant, so came from the private sector, from KPMG and Empower Consulting, wonderful firms, and have been in the NHS for 15 years, doing varieties of different things, but latterly I've come back to my roots in the last 2 years and sort of re-embraced my identity as a strategist. Strategy is a wide and interesting portfolio. Strategy directors come in very, very different shapes and sizes in the NHS and the wider public sector. My portfolio, I'm extremely lucky. It's very broad and includes our Anchors program, that's language actually that we don't use. We call it our social impact program, and it's really about how we go further than the straightforward delivery of the statutory responsibilities we have in community and mental health care to do better for our local populations. I also lead on research and innovation for the Trust. So I'm going to argue today that there is a place for strategy. However, we over-strategize in the NHS. We call things strategy in the NHS that are not strategy because we want to elevate them and make them sound important and draw attention to them. But in fact, they are no more than a fancy plan. Right? So I'm going to make the distinction later on between what is a strategy and what is a fancy plan. So we'll come back to that one. But otherwise agree very, very much with colleagues' definitions of what makes a good strategy. I'm a Richard Rumelt fan. He's an American business academic who talks that he has a wonderful book, Good Strategy, Bad Strategy. It's a good one to read. And he describes the three core components of a good strategy as one that has a very clear diagnostic of the problem we're trying to solve. We don't write strategies to keep folks like me in long trousers. We write them because we're trying to do something very specific and targeted. So that's your point about the evidence base. His second component of a strong strategy is about principles people can get behind. So, for me, a strategy is something that brings people together. So the key principles. And then there's the implementation plan and the coherent plan that is going to bring the thing into reality. And that's where we get into murky waters between strategy and fancy planning, but I'll come back to that.
Hello, I'm Liam Cahill, and it's great to be here. By trying to do the world's quickest introduction, 20 years in the NHS, I've been non-executive for a provider, I've been executive on an organisation that helped the NHS to plan how it would do innovation, productivity and prevention in medicines and prescribing, which some of you may remember. I don't think we're talking as much about that now. And I work with a number of organisations in the NHS around how do we navigate this evolving world that we're in, but I also work a lot with industry in terms of trying to understand this mythological beast that is the National Health Service and all of the different, I say beast, zoo full of beasts, because it's not one thing, right? So I guess in terms of strategy, look, a strategy is a piece of paper, right? And there's lots of methodology about how we write these things. But the work that I do and the work that I've done with a number of organisations in terms of going in and helping them think about how do we move forward into the future, I suppose always takes me back to a point that I remember really well when I was a non-executive and we were 2 years into a 5-year, I came in first, we did this 5-year strategy. 2 years in, we were like, it's just bullshit. It doesn't mean anything anymore. Like, the world has changed so much. You know, this was before the pandemic as well. And the reality is that most of the things that we wanted to do were inherently complex in nature. And I always try and spout the Cynefin framework whenever I can because it's not known enough. And there's like one thing that I think we really need to get to grips with, which is in the NHS and most of the public sector, we have this very Newtonian view of the world, which is if we break things down into reducible parts and measure them, you know, backed by the mantra of, you know, failing to plan is planning to fail, then everything will be okay. But the reality is we've Gantt charted the hell out of everything in the NHS, and we are not here to talk about bathing in the success of how everything is going really wonderful, right? We're in a very different environment. The world, driven by digital, is becoming inherently more complex. And complexity needs a different inherent approach, which is that we need to understand and navigate and then respond and not spend all of our time planning. And so I'm hoping that my cardboard cutout in this session is going to be around trying to talk about the philosophy that underpins what we're writing in these fancy plans or these strategies or whatever it will be, really, because otherwise none of it really matters if we've got the wrong philosophy that underpins and sits behind this.
Okay, thank you. So my first question then is about the word strategy itself. Okay, because it feels like to me like everything has to have a strategy. Strategy this, strategy there. You know, we'll strategize about this, that, and the other. You know, is the word so overused within the NHS that it's virtually become meaningless? You know, what should strategy mean to us in quite simple terms, if that's what it takes, in the context of our work in the NHS? And I'm not looking at anyone in particular. Who wants to start? Everyone's pointing at you,
Liam's
Anna.
I
just
feel like
pointed at
Anna's
me.
got a strong view at this already, but do you want to
I've
start?
got a strong view of a lot of things, but yeah, all right, I'll take it. Okay, look, so I opened up, I started talking about the difference between strategy and a fancy plan, and I'm going to elaborate on that in answer to your question, Phil. I slightly regret having coined this term. It was one of my very first sort of big addresses to our senior leadership group when I came into my current post a couple of years ago, and I started waxing lyrical about sort of thinking off the cuff, and I started talking about fancy plans. And what I mean by that is that I accept the accusation, if you like, that we over-strategize. I think we overuse the word strategy. I came into my trust, and one of the first things I did is go on the intranet era and put the word strategy into the search field, and there were about 11 billion returns. Excuse me. And the majority of things that were returned were variations on guidelines, policies, documents, plans, thoughts, all sorts of things. Very few of them required an actual strategy. So I went into slash and burn mode. And, a lot of them obviously were just out of date because nobody keeps up an intranet site properly. And in consultation, obviously not in a unilateral fashion, started talking to the owners of these documents. And actually, when I dug into it, there was quite a variable a variable interpretation of what the word strategy means. And quite often people said, well, this is very important, it needs a strategy. I said, so the correlation between important and this word, this magic word, seems to be a very strong one, which I absolutely accept. But I've tried to sort of talk everyone down and try and be really clear about what requires an actual strategy and what doesn't. And my analysis of what requires one is, what is the problem we're trying to solve? You don't write a clinical framework to solve a problem. You don't write an employee relations policy to solve a problem. You write it to manage a situation or to manage a workflow. But the diagnostic element that Richard Rumelt highlights in strategic planning and development is therefore a reason. And that, for me, is what distinguishes a strategy from a fancy plan. And I think we need to be quite strict with ourselves about what requires a diagnostic approach, a core set of principles and a coherent action plan from just the action plan by itself, because that's just a fancy plan. And I shouldn't say just. Planning is exceptionally important. There's nothing more to say about that, really. So that would be my response to the question, Phil. Thank you.
Just to build on that, I think they're all really good points. I think part of the distinction Anna's drawing there is there's a difference between being strategic and having a strategy. And, there's also a cultural issue, I think, in the NHS. I'm not here to talk down the NHS because obviously it's like an incredible global miracle, but also it's quite culturally broken in a lot of places. And in a lot of places, trust in individuals and trust in teams is replaced by paperwork. So my hypothesis would be the reason there are thousands of strategies is because everyone is constantly scrutinized, wants to be held accountable, and there's no empowerment of teams to work towards particular outcomes. So I think that's problematic. And finally, I think it is a buzzword. We're not going to get away from it, but I think we can recover I think we can help the reputation of strategy when strategy equals delivery. When we start to see delivery against a strategy, that's when people start to have faith and trust in it. And one of my favorite strategy excerpts I read out at at events and things is from the NHS's IM&T strategy from 1996. And what it says is, so IM&T being information management technology. It says staff will enter data, this is 1996. Staff will enter data once and share when needed. Information will be secure and confidential. The NHS will share information using common standards. So that was the strategy, the digital strategy in 1996. And I know we've made progress and it's a difficult problem to solve, but the more we can focus on not rewriting that strategy every time there's a new government, but actually delivering it, I think will get us into a better place.
I think I've done a lot of work with boards. I've got sessions that I do with boards to try and think about what they're asking for. And I always think it starts at the top because it trickles down. Try not to look at the chair of an integrated care board here. I'm going to look everywhere else apart from Arima. But quite often, I suppose, again, the philosophy and the mentality that I've often seen is that you get someone in a team who says, I've got this idea, I want to explore it, I want to take it further, we want to, this we can measure, but this we can't. And then it can go upwards and upwards and upwards. And there's so many memes on the internet that talks about as it goes upwards and then it comes back down, and it's become something totally distorted and arguably sometimes bastardized, right? And I think that the thing that I often see, and I think particularly when talking with boards is that boards feel, for example, many boards feel that they have a role in governance, which means to ask for more and to ask for more precision on this. And quite often I see that in board mentalities, what we have is this view that if we can't see exactly what's going to happen and how it's going to happen and when it's going to happen and what the future's actually specifically, explicitly going to be, then the strategy isn't acceptable. And sometimes what the board is actually asking for, which creates the culture in the organisation, the definition of what a strategy is they're saying, you've got to de-risk this, you've got to give us all this information. You speak to someone, you go down, you're saying, what are you being asked to do? And they say, well, if I put the answer, we don't know, we need to find out, then that's not going to be culturally acceptable in our organisation. And I think, there might be some of you in the audience who have some responsibility for strategy, but if it's going upwards and they send it back and go, computer says no because it's not good enough, then that defines in your organisation what strategy means. And I think it can be very difficult if we don't address at a board level their definition of what they can ask for and can't ask for, and what is arguably problematic behaviour in that sense.
Okay, thank you. So I guess we've touched there on the difference between a meaningful strategy and a glorified shopping list. Do you have any examples for our audience of times you've seen this done well? Good examples of strategy. I know initially we had this question as, can you think of any bad examples? We thought that would be a bit negative. So, yeah, examples of good practice where you've seen this work well.
Can I talk about the shopping list point briefly?
Please.
So, as my co-panelists have mentioned, like a strong theme that's coming out is that good strategy is around outcomes rather than widgets and things. So when you see these strategies that are just a shopping list of stuff, like it could be particular technologies that we're going to acquire over the next sort of handful of years, the problem with that is not only that it's a solution in search of a problem, and Joe Harrison was talking about this in the last panel as well, but also it allows the organization to other the strategy. What I mean is, if the organization sees a list of tech that needs to be delivered, they've got no they've got no skin in the game of the actual change in the organization that needs to make that happen. So, whereas if you have an outcome-based strategy, we need to, reduce the number of clinical safety incidents, that immediately, okay, there's a tech lens to that, but there's also an operational lens, there's also a clinical lens, there's also a management. So having multidisciplinarity around outcomes is a way of making sure that strategy is owned by the whole organization and not just the tech team.
Can I take that one stage further? So building things together is a key ingredient of strategy development. Undeniable truth, I think. Question is, who are we building it with? Now, obviously, this has a different correct answer depending on which organisation you're talking about, or in the case of health and care, which system, which set of partners. So I'll pick an example of good practice. Suffolk and North East Essex Integrated Care Partnership have a strategy. It's I can't remember whether it's their joint forward plan or their integrated care strategy. It doesn't matter. It's clever because it was designed with the communities, and it's communities plural because, a community is not homogenous ever. It was built together with communities, so it was deeply co-productive, another overused word, but it's correct to use it in this case. And I like it because it's known as the can-do strategy, which, you could argue it's a bit twee, but it's clever because it lists 22 things, quite a large number, that the partnership of Suffolk and North East Essex can do to address the, 12 uncomfortable truths. So it really, it lists some very specific things. It's got this clear diagnosis. It highlights through community engagement the 12 uncomfortable truths that we as providers have to front up to. It's a relatively countercultural approach, but it's yielded really good discussions, engagement, and fronting up, which is not always the case. It's got the 22 things we can do, and I would say that the majority of colleagues that I talk to in the Suffolk and North East Essex system can list 3, 4, or 5 of those 22 things that they feel bought into, engaged with, and that they, feel a degree of accountability for. So I'd point to that as a really a good quality piece of strategy work.
Yeah, I agree. I think it's a wonderful strategy. I think the work they're doing in that area is really, really good. And, I think it takes bravery to say we're not going to give everybody, or particularly in this environment, particularly with the pressure that's coming down from the top by CFOs in recent board minutes in NHS England and so on. Everybody wants all of the specificity around it, but to actually say, here's the problem, and let's think about how we can call as many people to action as possible. And before I mentioned when I was non-exec on the board of a provider, and our strategy became totally irrelevant. And we sat down and we were like, okay, do we need to write another strategy? And what we ended up doing is that, and the exec sort of went, oh God, we're just having to do back and forth. And so what we ended up doing was just this thinking framework that we called the dartboard. And the dartboard was basically the organizational philosophy that gave people agency to follow that, which is we invest in excellence, we try and use that excellence to spread to other areas that we can do, with a view of financial diversification as well, which of course is a reality in the National Health Service now. Every trust is talking about diversification at the moment, particularly when their SIP plan is 11% or something like that. So I think, within this, the best strategies I've ever seen is where it's designed for every single individual to find something that's meaningful to them and have the autonomy to move the needle, because there is no executive, including chief executives and so on, who can move that needle themselves, and they will, in the privacy of a room, admit that themselves. They need everybody to move a needle, and I think that's the most powerful strategies and versions that I've seen.
I've got a quick example that occurs to me from NHS app days, which accentuates, I think, some of the points my colleagues are making, which I couldn't agree with enough. So when Jeremy Hunt announced the NHS app, it was very solution focused. We'll have a national app, patients will be able to book appointments through it, and then all the metrics and the stuff that was driving me and my teams was like, let's increase the number of appointments that can be booked through the NHS app. Now, of course, anyone who sort of works in the sector knows that GPs are not entirely happy to make all of their appointments available online, because maybe they don't all need an appointment. Maybe they want a sense of agency and control about how those appointments get divvied up. There's all sorts of workflow challenges on the practice side. So maybe if that outcome gets set as, we want to find digital ways of enhancing, access to GPs through the front door. I don't want to make off the top of my head, but if you change the outcome to a more efficient primary care, then that introduces all sorts of other things, like maybe front door triage, maybe making sure people who need vaccinations get digitally connected to that service, or other nurse practitioner services, etc. So it goes to show that the type of metric and the type of kind of outcome you pick is really important. If it can be outcome focused, you can find different tactics to meet it, rather than just go down one sort of solution route.
Okay, I'd like to dig a bit more into the whole idea of user engagement. We've got massive NHS organisations employing tens of thousands of people. I wonder, if we chose a few at random, how many of those people would feel that they are involved in creating strategy? Is strategy seen as just, the activity for the elite few at the top, and then it trickles down? How do we get people invested in the strategy for their organisation?
We can't think about the future without thinking about the legacy, right? And if we've had decades and decades of people feeling strategy is something that's done to them, we need to start with a real conversation with them and actually say, we want to make this different. If we come and say, oh, we want engagement, we could probably pick hundreds of examples where engagement has been bullshit, total and utter bullshit, including at a national level. I probably shouldn't say this, but I remember when there was a huge national EPR consultation that happened, and then a big, powerful national leader came in with some unitary thing that they wanted to do that was, implementing a system across the whole of the National Health Service that nobody wanted to do, right? That wasn't based on user research. So what did that tell everybody? So I think if we want to tell a different story, we have to start by inviting people and helping them understand that we want to make the story different and have a bit of vulnerability. And so, I think pre-answering that individual question, we can't, I sit down with organisations and I go, oh, I'm here to talk about digital. And they all go oh, God, what are you going to do to us next? So we have to start by saying, actually, no, we want to do it differently. And I think any form of engagement has to consider the past and what people really think and feel about strategy or plans and so on in order to engage them.
I think we've got quite a few other mechanisms for engaging with, let's take staff of, the tens of thousands of people that work in any given NHS trust, without bringing them into another strategy workshop, right? We've already got the staff survey. We've already got, regular team meetings. If we demystify the thing and stop talking to people about strategy or about digital and switching them off with these words and just ask them a very simple question, right? I'm a big believer in the IHI approach to what matters to you. And we've got that already quite set out in the staff survey. It's nationally mandated, it's quite easily analysable. Unfortunately, the turnout rate is not where any organisation would want it to be. But I think actually if we use that as a tool to engage with staff on what matters to you, you get the diagnostic, and then through the natural mechanisms of internal teams and departments and the cascade up and down, and it has to be bi-directional, there are ways to talk about strategy without talking about strategy.
One of the risks I see around the engagement piece is that you can end up in a place where you're trying to please everyone, because a lot of people want things. So, back to the point about good strategy being around hard choices, I think a really important part of strategy engagement is helping people understand no, and why particular things are no and why not yet. So in my what I see in trust, like what I've seen in trusts before is like if you're the CIO or CDIO of a trust, you're saying no a lot because finite resources, it's complex to do things, But what can happen is if you don't make it transparent to people that everyone's getting a no, a lot of individual departments can feel that they're, being deprioritized, they're not feels, so you can breed this resentment. So making transparent the trade-offs, what the priorities are, the disagree and commit approach of leadership, and that collective responsibility, that's all an important part of engagement as well, I think.
We'll go to Liam first.
At risk of being contentious, he says too frequently.
Never.
If we're talking about user engagement, let's talk about the people's discussion that's going on at the moment being led by the government, right? I wrote a couple of articles. I remember going through it. And I remember being absolutely furious about how it was full of leading questions. Is prevention a good thing? Yes or no? The people have told us that we want to... What about having meaningful discussions, right? Apparently we've got this huge opportunity at the moment to really have meaningful discussions. And I knew the things that I wanted to advocate for in that response, and I found it impossible because the questions were crap. They were just utterly crap. And, I said at risk of being contentious. And I wrote an article about some of the questions that I would like to see around prevention and so on. Check it out on my LinkedIn if you want to read it. But, if we want an example of how not to do user engagement, let's take the biggest and most topical example at the moment, because it's really frustrating. And this is going to create the legacy of the next 5 to 10 years.
Anna, did you have something to add? No? I've had a 5-minute warning from the front, but a 10-minute warning from the back. So I'm going to go with the back. Okay, so we're going to go to the audience now. You've listened to all of that. Is there anything you disagree with, vehemently or not? Do you have any of your own challenges that you'd like to raise? Any questions, any additional perspectives? Gentleman here. Do we have another mic? Or? Can I ask you please to introduce yourself and where you're from? And if your question is directed at a particular member of the panel, please let us know as well. Thank you.
I'm David Hancock, and I'm an independent consultant. It's very interesting that what the panel have talked about essentially is that strategy is a social problem and not a technical problem. And reflecting on the NHS seems to see everything as a technical problem and not as a social problem. For example, the things they want to put in legislation, which indeed are social issues to be able to tackle, are not technical. So how do you think that for the NHS as a whole, do we begin to get them to realise that things are social and not technical? They will take longer, but it's like the hare and the tortoise, isn't it? If you go slowly like the tortoise, but address the social problems, you will get there far more quickly than the hare does.
Thanks, David, for your question. A small build, I would say, I wouldn't say they're social, not technical. They say they're social first with a technical element. So public digital has if you go to definitionofdigital.com, our definition of digital is there, like others are available, but it's using the culture, processes, operating models of the internet era to respond to people's raised expectations. So the technology is important, but as you say, sort of meaningful cultural operating model change is part of it as well. I think the way through that is true multidisciplinarity at the very top of the table. Like again, digital, when it's seen as IT, it gets othered in this as it was in NHS digital, it's this place over here. Where is that multifunctional conversation happening? A trend we're seeing in trust across the country is bringing together digital with transformation and improvement within trust. Because if you've got 3 different change agents effectively in an organization pulling in different directions, then you're not going to know which way is up. So for me, the answer is ensuring there's a multidisciplinary conversation at the center of all that strategy.
Okay, thank you. We're going to do one panel answer per question so we can get through more. Does anyone else have a question? Yes, gentlemen, just behind you, David, please. Thank you.
Hi, my name is Hunter. I work for a company called Thalamos, which is digitising mental health care pathways. Question is, as someone in the private sector, interested in any tips on engaging with the NHS and NHS organisations through their strategies. So it's coming across a strategy and using that as a bridge into a conversation, how that's done effectively, and based on not knowing whether that person actually has had any involvement in that strategy themselves, but it is an output of their organisation.
Yeah, like, as you say, don't expect that every single person you speak in the organisation gets up and chants a strategy every morning is probably the first thing, right? But actually, only you, Anna. But you wrote it, so that's okay. But like, I think the thing is, it's a good place to start. Sometimes we've got to meet the NHS where they are, and we've got to go towards them. And actually, the fact that the strategy is publicly available documents, it will give an idea of the ethos of the organisation and how it functions. Like, I would say, don't expect that everybody knows it and that they have it in their mind and that they get up each day and see how it's going to guide them. It'd be lovely if that was the case, but at the same time, not going in and not knowing what their strategy is when the documents are publicly available is just almost laziness, to be honest. Like, it's there, so go and read it. And if you want to talk to them about mental health, go and look at their board papers and talk about what they've done, or look at their digital strategy and so on. Because actually, if at some point in the future you're going to have to write a business case, like, being able to outline what they've said in their own strategic objectives and making it relevant to that is a really useful place to start, regardless of the quality of the strategy itself.
Okay, thank you. One just down here, please. Can we have the microphone up here? Thank you.
Hi. So, you're talking about sort of strategy, culture, and it's talking about strategy and culture and people being aware of the strategy, engage with it. What percentage of staff in the hospital, particularly those on wards, do you think are, like, not even engaging is one thing, are aware of it? I think I've seen 3, and everyone's screensaver changes, and you get a lanyard with some adjectives on it. Like, how is strategy engaging with like 90% of the workforce?
Well, the short answer is your analysis is probably right, that it's a very tiny proportion of people that, you know, can chant the strategic objectives or whatever. Now, there is a prevailing school of thought that in itself is problematic. My controversial opinion is that it doesn't matter. It doesn't matter that the majority of staff in an organisation don't think about, can't talk about, maybe aren't that interested in the strategy. What matters is that the thing that drives them and that gets them up in the morning and makes them come to work for that organisation resonates if someone did talk to them about the strategy with what the strategy says. And, you know, a good manager and a good, you know, service manager or whatever should be having those conversations now and again to test that there's a resonance and an alignment. What I've discovered works better, rather than talking about strategy in kind of abstract, academic, mystifying terms, which actually others people and keeps them away from you, is to do it in kind of story form. And I saw an amazing example of this literally last week, where a local GP in our system who has a system leadership role was at a research engagement network event talking about his vision for engaging marginalized groups in his research strategy. And he didn't use the word strategy, he didn't talk about engagement, he didn't talk about anything, he talked about his own story. And people in the room, which were largely members of the public and representatives of the voluntary sector, were visibly engaged and excited because he was talking about himself and what it meant to him. So I think the fact that maybe 3% of people know what it means doesn't matter. We've got to involve storytelling to get them there.
Okay. Thank you all very much for your attention. Thank you for your questions. We need to leave it there. Please show your appreciation for the panel.